Today we'll be discussing about malignant otitis externa. As the name goes, malignant otitis externa is not malignant. It is not cancer. It is an infection or inflammation that starts in the external aortic canal. It is called malignant because it is a life-threatening condition and it can spread to the surrounding areas of the ear immediately. That is why it is known as malignant otitis externa. Another name for malignant otitis externa is necrotizing otitis externa. What is the etiopathogenesis? Usually, the malignant otitis externa is seen in an immunocompromised patient, most commonly seen in diabetic patients, and there is a male predominance. And in diabetes, the problem is due to the long-standing diabetes and uncontrolled blood glucose, there is small vessel vasculopathy, and the immunity of the patient is reduced, or the immune function of the patient is reduced. And also in diabetes, we can see that the pH of the external aortic canal, pH of the wax of the external aortic canal is found to be alkaline. So higher pH and reduced lysozyme, so they are more susceptible to develop external ear infection. Also, it is seen in other immunocompromised patients, such as patients on cancer chemotherapy, patients with chronic kidney disease, HIV patients, etc. The most common organism isolated from malignant otitis externa is a gram-negative bacterium known as Pseudomonas aeruginosa. Pseudomonas aeruginosa can produce exotoxin and also other various enzymes like lecithinase that will help to invade the surrounding area, and the inflammation can spread fast. Other gram-negative organisms are also found, Proteus, Klebsiella, etc. Gram-positive organisms that are isolated are Staph aureus. It can be methicillin-resistant Staph aureus and Staph epidermidis. In HIV patients or other immunocompromised patients, fungal species like Aspergillus and Candida can also cause malignant otitis externa. What is the pathogenesis? So initially, the malignant otitis externa start as a otitis externa. The patient will give some small history like I cleaned my ear or I poked my ear with a finger. So a trivial injury, patient will get infected. And initially, it starts as an otitis externa, and then it can spread along the facial planes, and it causes the osteitis and chondritis. That is the cartilages involved, the bones, periostitis and osteomyelitis. This can spread to the temporal bone and into the skull base. Anteriorly, it can spread to the parotid. Anteroinferiorly, it can spread into the stylomastoid foramen, involve the facial nerve. Facial nerve is the most common cranial nerve affected in malignant otitis externa. It can involve the temporomandibular joint and the condylar bone marrow. Immediately, it can spread into the parapharyngeal space, into the nasopharynx, into the sphenoid bone, and involve the glossopharyngeal spinal accessory nerves. It can spread into the temporal bone and into the skull base, into the petrous apex. It can spread into the brain, causing meningitis, dural venous sinus thrombosis, brain abscess, etc. What is the clinical presentation? The clinical presentation is almost always ear pain. So the ear pain is not responding to treatment. Severe ear pain. Patient is having ear pain severe at night, that is nocturnal otalgia, ear discharge. Patient can also present with any of the cranial nerve palsies. Most common is facial nerve palsy, so deviation of angle of mouth to the opposite side. On examination, there will be pain all over the ear. The auricle can also be red and painful. There is tragal tenderness over the mastoid. There will also be tenderness between the mastoid tip and the ramus of the mandible. This area, there will be severe tenderness for the patient. On otoscopy examination, you can see a granulation tissue. The granulation tissue almost always arises from the bony cartilaginous junction of the external aortic canal, and it can usually fill the external aortic canal, and it can be seen from the outside the ear canal also. Usually in this cases, phlegmatic membrane will be normal. What you have to see is if an HIV patient is presenting with similar complaints, there may not be a granulation in the external aortic canal, but you should keep in mind a chance of malignant otitis externa and more of a fungal etiology. So how do you evaluate this patient? You do a routine blood examination to know the counts, and you do the blood sugar examination like fasting blood sugar, postprandial sugar, HbA1c to see the blood sugar control. From the ear, a swab can be taken for culture and sensitivity. Also, blood parameters, you can monitor ESR and CRP, which should be elevated. The main function for ESR and CRP is you can monitor the response to treatment. Once the patient starts responding to your antimicrobial treatments, the ESR and CRP will start coming down. So you can know that the patient is responding well to your treatments. What are the imaging that can be done? You can do a CT temporal bones. HRCT temporal bones can be done to identify the bone erosion. There can be erosion of the external aortic canal and also the mastoid area, and also there can be obliteration of the fat planes in the subtemporal area. MRI is done is mainly for soft tissue involvement. MRI can help to identify the dural venous sinus involvement, any thrombosis, intracranial complication. For all this, an MRI can be done. Contrast MRI with MRI angiogram, MRI venogram, all that can be done. Problem with CT and MRI is it cannot differentiate an active infection or a resolving infection. So there are other radionucleotide scans that you can do. The first one is technetium 99 methylene diphosphate bone scan. As the name goes, it is technetium 99 bone scan. So the technetium 99 is taken up by the osteophytes. So you can see the osteolytic and osteoblastic activity. So technetium 99 scan is used to identify early disease. If there is any early osteomyelitis, technetium 99 will pick it up. Then there are other scans known as gallium 67 and indium 3 scans. Gallium 67 citrate leukocyte scan. So gallium 67 leukocyte scan. So the gallium 67 is picked up by WBCs. So it shows inflammation. So it can predict the resolution of the disease. That is, if the gallium 67 scan is reducing, that is, the uptake is reducing, it means that the patient is going for resolution. The indium 3 is also same type of scan. You will get an accurate diagnosis if you combine the radionucleotide scan with the SPECT or the CT scan. Some centers do a PET CT also to identify the location and the extent of the malignant otitis externa. CT, MRI, protein investigation, technetium 99, bone scan for early detection, gallium 67 or indium 3 for prognosis. Any centers, if you're working in a small hospital, you may not have a technetium scan or a PET CT scan. So we have certain criteria to diagnose. The most common criteria that is used is Levensons criteria. So one is, as I told earlier, refractory otitis externa. That is otitis externa not responding to normal treatment. Then the patient is having nocturnal otalgia. That is severe nocturnal otalgia. Purulent otorrhea. That is ear discharge. So otitis externa, ear pain, ear discharge. Then on examination, you can see a granulation present in the auditory canal. If when you take a pus culture and sensitivity, Pseudomonas aeruginosa is detected and patient is having diabetes mellitus or immunocompromised situation, you can right away diagnose it as a malignant otitis externa and start treatment. There are other criteria also known as Cohen and Friedman criteria. That is also same only. The name and everything will looks big, but it is same only. He has just made it into major and minor criteria. So major criteria same only, refractory otitis externa. He just said that if the otitis externa is not resolving within 1 week, it can be told as refractory otitis externa. Then exudates and ear discharge. Then you see granulation tissue in the external auditory canal. The two new things that he has added is he has added a positive technetium bone scan, and also if you're doing a surgical treatment, you have to, if you identify micro abscess in the surgery, it is a major criteria. So the immunocompromised state, he put in the minor criteria, that is diabetes, debilitation, old age, any cranial nerve involvement, all this comes in the minor criteria. What is the treatment? So the treatment is multi-modal treatment. First one is oral toileting and oral hygiene. The ear is cleaned of any secretions and discharge, and you give topical and systemic antibiotics. Topical ear drops, you can give ciprofloxacin or fluoxetine ear drops, polymyxin B ear drops, all that you can give. And oral systemic antibiotics are given to patients with minimal disease and no complication. So the first line of treatment you give is a fluoroquinolone, that is ciprofloxacin. Fluoroquinolones are broad spectrum antibiotics with good gastrointestinal availability. So oral antibiotics can be given in the initial stage or a mild disease. In other cases, you give an IV antibiotic, IV fluoroquinolone or IV ciprofloxacin can be given. Ciprofloxacin is an excellent antibiotic with good tissue penetrability, but because it is less costly available in developing countries, it is misused. That is, it is broadly used. Resistance is emerging for ciprofloxacin. So if ciprofloxacin resistance is suspected, you can give other IV antibiotics like ceftazidime, ticarcillin clavulanate, aztreonam, which can be combined with an aminoglycoside antibiotic like gentamicin. Also, you can give gentamicin drops also. Supportive treatment is control of the blood sugars, And if the patient is a kidney disease, chronic kidney disease patient undergoing dialysis, all that parameters has to be brought within the normal limits. Some patients may have electrolyte imbalance. All the general condition has to be brought within normal limits. In fungal malignant otitis externa, mostly the treatment of choice is amphotericin B. You can also give itraconazole and voriconazole. Other treatment is some centers provide hyperbaric oxygen therapy, which is an adjuvant to medical therapy. Surgical treatment is reserved for patients who are not responding to medical treatment. You can do a local debridement, clear the bony sequestra. If there is any abscess, you can drain the abscess. In facial nerve palsy, usually facial nerve decompression is not recommended in otitis externa because many studies show that there is no difference in prognosis with the surgical treatment. Another important thing is you can take a biopsy from the external aortic canal because you have to differentiate the malignant otitis externa from a squamous cell carcinoma of the external aortic canal. Usually the biopsy will show ulceration, epithelial loss, features of acute and chronic inflammation. In some patients, that can be pseudoepitheliomatous hyperplasia in the histopathology examination, which makes it difficult to differentiate from a well-differentiated squamous cell carcinoma. So always keep in mind you have to take a biopsy to rule out any squamous cell carcinoma of the external aortic canal. Prognosis, the prognosis is usually unfavorable. In mild cases, they will recover. Mild cases, patient not having too much comorbidities and the blood sugars are made under control, they might recover. But there's a chance of recurrence. In 1 year, patient can develop the same problem. If the patient is having a lot of granulations and facial nerve palsy and all, there is a less chance of complete recovery. There are two other criteria for assessing the severity of the malignant otitis externa. I will explain that also, especially for postgraduates. There is something known as Peleg stratification. So Peleg stratification consists of 4 points. If each point is present, you give 1 point is given. So if the points are increasing, if there's more than 2 or 3 points are there, means the disease is severe. 1 is diabetes. 2 is involvement of the temporal bone on CT. 3 is CT showing involvement of the skull base, that's beyond temporal bone into the sphenoid, occiput, or the clivus. 4 is CT showing involvement of the temporomandibular joint. So if the temporomandibular joint is involved, it is a severe disease. There is another staging system known as Carney clinico-pathological staging system. That is, it is divided into 4 stages. Stage 1 is there is clinical evidence of malignant otitis externa, but the patient is having a technetium 99 bone scan negative. Stage 2 is positive technetium 99 bone scan. Stage 3 is cranial nerve involvement. It is divided into 3A and 3B. 3A is 1 cranial nerve involvement. 3B is multiple cranial nerve involvement. Stage 4 is there is meningitis, brain abscess, that is intracranial involvement. All this can be used to assess the severity of the malignant otitis externa.